Good evening and welcome. Thank you for joining our fifth Enclave webinar on managing lung cancer patients through the COVID-19 pandemic, What to Know. I'm your moderator this evening, Gina Columbus. I'm the editorial director for Enclave, and it's a pleasure being with all of you again tonight. If this is your first time joining, just some background might be helpful. The mission of this webinar is to provide our listeners with a free-form discussion on how you and your colleagues are managing your patients with lung cancer during the COVID-19 pandemic. Tonight, and as we have over the past few weeks, we will cover specific areas of discussion that each faculty member will go into greater detail on and share their insights from the front lines. As you can see from the slide, tonight we will be gaining some outside perspectives on radiation strategies in the era of COVID-19 from a very special guest tonight, who will also give some insight on how practice has evolved as the COVID-19 cases have risen in the New York, New Jersey area. We'll also touch upon the wellness and stress of healthcare workers and physicians and a case-based discussion as well. So we do have a few housekeeping notes. If you are listening to this webinar, we encourage you to submit any questions you have, and we'll try to answer as many of them as we can during the Q&A portion of this webinar. We're actually gonna, similar to last week, we're gonna kick off the Q&A section a little bit earlier tonight, as usual, than to try and fit more questions than we're usually able to. So also to expand your video player to full screen, click on the icon on the lower right of the player. Hit escape on your keyboard to revert back to the smaller player. So we have a distinguished panel of experts on today's presentation, and I'm going to ask each of them to introduce themselves and give their title and affiliation. Dr. Aggarwal.
Hi, everyone. Good evening. I'm Charu Aggarwal. I'm the Leslie Heisler Assistant Professor for Lung Cancer Excellence at the University of Pennsylvania's Abramson Cancer Center. We have a terrific show tonight, so thank you for being here.
Thank you. Dr. West.
I am Dr. Jack West. I am a thoracic oncologist and associate clinical professor at City of Hope Comprehensive Cancer Center in the Los Angeles area. So happy to be joining again today.
Thank you. Dr. Pennell.
Hi, I'm Nate Pennell. I'm a thoracic oncologist and associate professor of medicine. I'm the director of the lung cancer medical oncology program at the Cleveland Clinic in Ohio.
Thank you. Dr. Liu.
Hi, I'm Stephen Liu. I'm an associate professor and director of thoracic oncology at Georgetown University in Washington, D.C.
Thank you. And last but not least, Dr. Knoll.
Hi, everyone. I'm Dr. Miriam Knoll, or Mimi, as most of my friends call me. I'm a radiation oncologist in New Jersey. I actually live in New York, and I am very excited to talk to you today.
Thank you, everyone. And Dr. Knoll, thank you so much for being here with us tonight. We're very excited to have you and hear some of your insight. So as I mentioned, this is the fifth webinar in our plan series. So anything that's not covered during this discussion can certainly be raised in our next webcast. So we have a great deal of material to cover tonight. So let's begin. To start us off, and as I've done in similar weeks, I'm just going to provide some very quick numbers on the current state of COVID-19. So currently, as of a few hours ago, the number of global confirmed COVID-19 cases are more than 2.4 million, with more than 169,000 deaths. The US has 802,583 confirmed cases with 44,575 deaths. Meanwhile, we are all continuing to observe the social distancing guidelines that have been instilled upon us, but this is much more challenging to follow for our patients who have serious medical conditions that do require urgent attention. Over the last several weeks, we've discussed how COVID-19 continues to impact so many aspects of our personal and professional lives, and especially as we are talking about tonight, how our experts manage lung cancer in their patients for preventive measures they're taking in practice. So tonight, we're going to be diving into more of these very important topics in this space. With that, I would like to turn it toward our discussion with Dr. Knoll. Our panel has several questions for you, but first, would you be able to kind of share your perspectives on how the pandemic is being handled in the New York, New Jersey area and how things have evolved as the number of confirmed cases continues to rise, and how are your strategies changing, especially as they relate to radiation?
Sure. So I think we're really at a great time in terms of the surge in New York, New Jersey to have this discussion, and specifically about lung cancer, which we know is a very serious disease and one that can be very difficult to cure. And that is also very, very prevalent in the United States. So I would say that, when coronavirus hit the United States, New York and New Jersey both became areas that had a very large surge very, very quickly. So within that first week, everyone was, to put it mildly, freaking out. Okay. And the motto was stay at home, stay at home, stay at home. I remember I had seen a patient for actually something benign that I had treated with gamma knife. And I remember saying to him, like, why are you here? Go home. Like, everyone, don't come to the hospital. But at the same time, it's been a couple of weeks and we have patients that we need our help. They need curative treatment. And it's something that we really need to figure out how to do in the safest way possible. So with coronavirus, we know that we have a couple of goals. Number one, we want to keep the staff and everyone that works in the hospital safe. And we also want to keep our patients safe. So I think that in New York, New Jersey, definitely in the hospital where I work, and I know where a lot of my friends and colleagues work, we have been able to give personal protective equipment to both the staff and the patients. And I think that's a really an important thing just to realize that, and this is something that I tell patients who do need to come in. If you are walking into the cancer center, you will get a mask. Everything is cleaned. We are doing everything that we can to make sure that we are not giving you coronavirus. That being said, obviously there are still risks anytime someone goes out of their house, and certainly comes for radiation. As we all know, radiation is a treatment that is usually more than once. There are some SPRT treatments that can be given once. We call that radiosurgery, but most of the time it's every day for a couple of weeks. And depending on the type and stage of lung cancer that we're treating, it can be up to 6.5 weeks. And therefore, we again are concerned about both the staff and the patients, and patients giving it to each other. So I think another thing just to mention that again has really changed very, very rapidly is that we have patients that would normally be coming into the hospital for consults and follow-ups, and we are not doing that. We're instead doing telemedicine. So again, that decreases the amount of patients physically in the building at any time. And patients usually in a radiation department will be sitting together and talking, and people actually kind of make friends, because they see each other sort of at the same time every day when they come through radiation. That is not happening. Instead, patients are waiting in their cars. They get a phone call, they put their mask on, they come in, they get their treatment, and they run out. So there's really no time that they're sort of hanging out in the department. And then the last thing, which I know we want to talk more about, is, well, how many times is that patient going to be coming in, right? So if we want to decrease exposure, the best way to decrease exposure is to decrease the amount of times that a patient is physically coming in. And that really depends on a lot of factors, including when the patient was diagnosed, when the patient was supposed to start radiation, what other things are going on in terms of the patient's medical history. How worried are we that they either have coronavirus or could get coronavirus or could get very, very sick from it? Obviously, that's an unknown, but we do have good information that if someone is elderly, if they have comorbidities, if they're, had a lobectomy or, a pneumonectomy, obviously they're at a higher risk.
So I think, Mimi, this is great. I think in line with what you said about limiting exposure, when we started doing these series and when we started talking about our strategies for preventing the spread of this virus and, mitigation strategies, we had said we would like to, on a case-by-case basis, delay treatment as feasible, but we are obviously quickly realized that we are in this for the long run, for the next few months, till potentially the fall. So at our center, we have been discussing strategies to reduce the number of fractions patients receive, especially in the curative setting.
Mhm.
What are your thoughts about using hypofractionated schedules as have been studied, like in the CLGB trial or in the soccer trial, looking at limited number of fractions, but still with the definitive intent for stage 3 lung cancer. And how have you handled that?
So I agree that for a patient with stage 3 lung cancer, we do not want to delay treatment. So if they are ready to go, we should not delay it specifically because of coronavirus. I think that if a patient is getting radiation alone, that's definitely someone that should be hypofractionated. There are, a couple of different published guidelines, anywhere from 15 fractions, 20 fractions, and that's a significant difference. We're going down from 6.5 weeks to 4 weeks or 3 weeks. The studies that you mentioned were very small. I'm not comfortable doing concurrent chemoradiation and doing hypofractionated radiation, but I definitely would feel comfortable doing that if we did sequential treatment, chemotherapy first and then radiation alone. That's my personal experience treating patients, but that's also Estro and Astro published guidelines in the Green Journal about 2 weeks ago. And that was also a consensus that for a patient with stage 3, definitely they should not be delayed, but they should also not be hypofractionated simply because of coronavirus, and certainly not with concurrent chemoradiation.
So Mimi, can I ask,
Sure.
the setting of stage 3A disease, especially 3A and 2, has long been one where there are different ways to potentially play it. There's often a somewhat heated multidisciplinary discussion about should this patient have a surgical approach, should they have chemoradiation, and I think you could argue that in the world where there is a risk of coronavirus just from going into the hospital or the clinic, you could make the argument that if you have surgery, you save weeks and weeks and weeks of daily visits and instead do a short-term process and get in and out. On the other hand, we've also seen that the patients who have had surgery have a higher risk of coronavirus infection and complication or COVID-19 issues. And at the same time, you are in the eye of the storm right now between New York and New Jersey. And now I don't know how feasible or attractive it is to the docs, the hospitals, or the patients in terms of having patients come in and require ventilatory support versus get managed probably as an outpatient. So
Yeah.
How has all of this changed the equation? Are patients, is everybody who could be handled with chemoradiation instead of surgery getting that, or are people inclined to just do it with one intervention rather than 6 or 7 weeks of daily visits for radiation?
Yeah, so I appreciate the question, and I think what the way that I think about the question is, what should we do and what can we do, right? So those are two very different questions. So the first question, what should we do? That's in a tumor board, right? So yeah, for a stage 3 patient, we're going to have a discussion or an argument between all the oncologists around the tumor board table. And then there's what can we do? What is actually feasible? So as of today, there have been, no surgeries, no elective, which includes lung cancer surgery, and Hackensack. So, our thoracic surgeons are, not able to do surgery. They've been actually manning the ICUs. Thankfully, you had mentioned respirators, so I'll just comment that, we have not had a shortage of respirators, and I think that's because of the really great work that everyone has been doing to secure respirators and to make sure that we have enough. So I'm not aware of any patients in New York or New Jersey that needed to be ventilated that were not. Obviously, that was a great fear, but we've been able to avoid that by getting the supplies that we need. So At the same time, again, what should we do versus what can we do? On Friday, they're starting lung cancer surgery again. So I think when things are delayed by only, 2 to 3 weeks, it's sort of easy to continue doing what you want to do and what you've always done. We haven't gotten to the point where our hands are tied. But if that were to happen, again, it sounds cliche, but it really is on a case by case basis. I think that it's important to realize also that, the patients that we're most worried about are the ones that we're already worried about. And lung cancer is very much a surgery driven disease, in the sense that, as a radiation oncologist, I'm never going to tell a patient don't have surgery. I'm never going to tell a patient you can't have surgery. I'm going to tell them, go see the surgeon, let's see what they say, and then we'll all discuss it. So if a patient is a surgical candidate and we're worried about coronavirus, are we going to wait, 2 weeks for the surge to go away? Yes. If at that point the surge is still surging and, the patient can't get surgery, sure, I would start radiation, but that actually hasn't happened yet. And I guess that's a good thing.
Mimi, I was wondering, one of the bread and butter things that we work with radiation oncologists to do is delivering palliative radiation. And these are often cases where the patient's very symptomatic and can't wait 3 weeks or a month in order to get some kind of palliation of symptoms.
Yeah.
So, what are you changing the way you're approaching someone who's referred to you for pain, for hemoptysis, someone with cord compression in the hospital? Would you think about it differently now versus you might have a few months ago?
Yeah, so I think the question for palliation is easier to answer. The reason why we're treating a patient is always to make them feel better, and it's always to first do no harm. So, if someone has, a month left to live, we're not going to spend 2 weeks of their life giving radiation ever. It's certainly not with coronavirus. So, anyone that is coming for pain is getting, one treatment. Why don't we always do one treatment? Well, we know patients tend to come back, but at this time, I'll be happy if a patient comes back in 3 weeks or a month or 2 months for more radiation. So I'm happy to give them a single fraction instead of, the normal, 5 or 10. Certainly, if a patient has a brain metastasis, that's also something that needs to be started right away. Usually we can, schedule a radiosurgery quickly. And then in terms of palliation for dyspnea or hemoptysis, also that's something that we routinely would start right away and it would never delay. It can be a little challenging to hypofractionate for a collapsed lung, because usually the area that's collapsed is contiguous with the area of tumor. So it's sort of hard to tell where the tumor ends. So we usually treat quite of a large area. And I wouldn't feel comfortable treating that with a single fraction, but I certainly would be comfortable doing it with 5 fractions, and potentially even 1, depending on the area. And again, needs to be planned, obviously, with a palliative lens, because, for example, if we're including the esophagus, we don't want to blast the esophagus and the patient can't eat for a week. So, we need to plan it in a way, but that's certainly something that we can very comfortably do. So we're definitely shifting towards as few fractions as possible, and even 1 when needed.
Yeah, I think that's a great point. And, we want to keep our patients at home, try to minimize their risk. As medical oncologists, we get asked a lot about skipping cycles, about interrupting treatment, delays in treatment.
Yeah.
Radiation oncologist, were your patients, as your numbers started to rise, were they asking about interruptions? Were they maybe not coming? And can you explain from a biologic standpoint why that's so important to avoid?
Sure. So I would say in the first week, when everyone was going crazy, I had patients who were asking, can I get tested? Can I get tested? And my very strong hunch is that the reason why we saw a rapid increase in cases in New York and New Jersey, and then a slight decline before it went up again, is because in the beginning, people were rushing to emergency rooms because they wanted to get tested. And then people realized, don't go to the emergency room unless you're symptomatic. So we definitely had a lot of panic in general, patients who wanted to get tested. And we just had to tell them, if you're feeling well, let's hope you stay that way when, we don't have the ability to test everyone. Then, it's shocking to me, and it's always shocking, and it continues to be. Patients with cancer are just so incredibly strong and so incredibly committed. They really show up, even if it's a blizzard, it's a snowstorm, it's coronavirus, they show up. So everyone has a mask, everyone is screened, everyone has their temperature checked, everyone is Purelled up and down before they walk in. And we're very, very strict about that. And they're very strict too, but we have not had patients canceling specifically for coronavirus.
Can I just go back to the question of palliative treatment and these shorter regimens? There have been data showing that you can do palliative radiation for bone mets in just 2, 3, or even 1 fraction. We just generally don't do that. And so my question is, now that we're doing this in the setting of COVID, is that going to stick? I think, is this something we should have been doing all along and just haven't? Because things like telemedicine.
You took the words out of my mouth.
Telemedicine has been out there as something we probably should have been doing more, but didn't get around to doing. And now we've catalyzed that. And I think that's going to stick. It's not going to be probably as common or as in-depth as it is during social distancing, but is this kind of an overdue change that should be sustained?
Yeah, so one of the great papers that I love about palliative treatment, short course versus long course, is a paper out of Canada looking at how likely a department is to adopt shorter schedules depends on how much of their faculty trained at one location or the other. And basically, the idea is that when you learn something from your friends or your colleagues, you're like, hey, I can do that, right? And that's one of the amazing things about social media and Twitter and the Facebook groups and everything. You get ideas from people like, hey, I can try that, I can do that, right? And it's not only the idea, it's also, the whole process. We all know that we have an idea how to treat our patients, but it's not really up to us, right? We have a whole staff, we have a whole administration, there's a whole operation that has to get done what we want to do. And it's very much like that for radiation, right? So, number one, I see a patient in consultation, then I have to send out an email, let's schedule a patient for stimulation. I mean, there are, 30 people on that email, right? And then there's the stimulation, there are the therapists, and then there's a physicist and the dosimetrist, and everyone has to plan it and do the QA and get it done, right? So that whole entire process is something that everyone is used to doing something a certain way. And it's not easy to make those changes because, again, we all take our jobs very seriously, right? We, oncology, radiation oncology is very high job satisfaction. People really do what they do because they want to do the right thing and they want to do it the right way. And they know that the risks are high, right? Radiation can kill people if done incorrectly. So to your point of, now that we've taken that leap and have, let's say, done something in a new way and have seen that we can do it with a new protocol, a new way of doing things, new way of where the patient's sitting while they're waiting for the radiation to be planned, right? Because they're not going back to the nursing home. All those logistics and things, once you work through them, yeah, I agree with you, and I think it's appropriate, and I look forward to being able to do things in a new way now that we've shown that we can do it. And definitely with telehealth. I mean, I love how within a week everyone was doing it. And Astro actually had to clarify with CMS whether the expanded guidelines also covered on treatment visits. It sounds like a little thing, but there's a billing code for it, and people didn't want to lose that revenue, right? So Astro actually had to reach out. And they did, and they were able to say that, yes, it includes on-treatment visits, which, based on my Twitter poll, half of radiation oncologists were doing anyway, but I think hopefully more people will do that. And that's good for patients, and that's good for us.
One of the things that you touched upon was how quickly we've adapted to certain things, and telemedicine is certainly one of them. But universal masking, for example, and temperature screens, Purell, hand washing, social distancing. I mean, everyone's really got used to this and has adopted this very favorably. And then the question comes in of, can we take this a step further to reduce exposure? Certainly for our highly myelosuppressive regimens, and for example, for CAR T cell patients or bone marrow transplant patients, it makes sense to perhaps test them for COVID before starting treatment or before their inpatient elective admission. We've toyed around with the idea of testing patients before, let's say, beginning concurrent chemoradiation, but there are lots of problems with it, right? I mean, if you test negative one day, doesn't mean that you won't be positive the next day, and then the false negative rates. And just wondering what your thoughts are about testing patients prior to, let's say, starting concurrent chemoradiation. Have you guys thought about this at your center? And what are you going to do about this if in case this is going to be enacted?
Yeah, so I think again, it's one of those things that is something worth thinking about. I don't think it's something that makes everything easier, right? It's just one of those things that is a tool in our toolbox. It certainly would require a tremendous amount of coordination and organization on the administrative level, which, if it's going to happen, would have to be implemented throughout the cancer center. So it's not something that we're doing right now. It's something that we're definitely thinking about. I agree that, universal, masking for all patients, for all staff. We're doing that now. Everyone who walks in is having a temperature taken. We have very strict no visitor policy. Unless someone has a wheelchair or needs help, with mobilization, then, people are not allowed to have anyone else accompany them to visits, in addition to just overall decreasing the number of visits. I think, to your point about, how on top of this worry do we need to be of, who's going to be getting coronavirus at any point in time. There are a few anecdotes of, and there's a study now happening at Northwell Health, which is in Long Island, looking at the CT simulations of patients coming for lung cancer treatment, right? So it's a scan that we're doing anyway. It's not a diagnostic scan, but it's certainly possible to pick up on early signs of coronavirus. And that's something that Lou Potters, the chair at Northwell, has picked up on in some of his patients. So I think that our suspicion needs to be high. Anyone with a cough needs to be tested. Anyone with a fever needs to be tested. What I would really like to see, honestly, is a very widespread testing system throughout the entire United States, right? I mean, if everyone was tested, like in South Korea, I think we would all be better off. So that's, a step that I hope we'll be going towards, because that's really the only way for us to, quote, go back to normal, whatever normal is. Until we institute very strict testing, there's no way that we'll be able to contain this and also continue to not have to stay at home.
One question I wanted to ask is about, there's been building momentum for consolidation radiation, typically SBRT, for oligometastatic disease. Certainly in lung cancer, there's been some growing data. It's not a clear standard of care, but my experience is if you talk to radiation oncologists, they'll froth at the mouth about it. And it's really, it's a real conceptual change. And I think it's gained momentum, I think, among non-radiation oncologists as well. Still needs more study, but I think a lot of patients are, at least selectively, have been getting referred. And I'd like to know whether in this environment, those kind of arguably optional wants, not necessarily needs, in the same way as limited stage small cell would be. Are these now getting deprioritized, or do you still have you and colleagues with enthusiasm and interest in pursuing consolidation for 1 or 2 residual metastatic lesions for someone who's several months into targeted therapy and had a good response?
Yeah, so I think more than anything else, it's a pipeline issue. These are patients that, are managed. The quarterback is the medical oncologist, right? So we know patients, treatments are getting delayed, their systemic therapy, they're on hold. That means that their scans are on hold. They're not going for scans. So, yes, there are some patients in the pipeline now that were planned, and I think it's reasonable to wait a week or two. If it's more than a month, I would say let's go ahead and treat those patients, meaning if they've already been scheduled and, there's a level of anxiety that also comes with, well, I was supposed to get it, now I'm going to delay it, and then they'll have to go for another scan and then replan for that. But in general, no, these patients are not a priority, right? They're metastatic, they're probably incurable, and it's not, for most patients, it's definitely something that can be delayed. But I think that it's sort of going to be an issue that is not going to come up much because then these patients are just not going to get referred to us.
Right.
And one of the other things that has been going on in New York and New Jersey, of course, is because it's been so crazy, even what we might not consider truly elective, but cancer surgeries have been impossible at some hospitals. Given that there is already a dynamic of this, somewhat friendly disagreement between radiation oncologists and thoracic surgeons about which patients with early stage cancer should get surgery, which should get SBRT, has this changed that dynamic at all? Have you seen or heard of pressures of patients who might otherwise maybe be a high-risk surgical candidate getting pushed further towards SBRT so they don't have to delay?
Yeah, so, I'm more on the friendly side of this discussion with the surgeons. I really do think that lung cancer is a surgical disease, and I defer to, my surgeon colleagues about whether or not someone is a surgical candidate. I'm not the one taking them to surgery, so I'm not the one that can tell them whether they should have it. I always say to my patients, if you could have it, you should have it. So, again, I think we're lucky that the surge was short. I hope to God that there isn't a second surge. I think, a month is a nice round number, and delaying things past a month is a bad idea. But if, patient surgery were canceled 2 to 3 weeks and then rescheduled, I'm okay with that. More than that, once we're needing to rescan patients, that scares me. So, one of the questions in the Astro guidelines was, if you had a patient that, exactly what you asked, if there was a patient with early stage lung cancer that was referred for radiation specifically because they could not have their surgery, would you go ahead and treat? And everyone unanimously said yes. Maybe because we're already doing that, right? We're already treating patients who can't or won't have surgery for early stage lung cancer, and we feel very comfortable treating them with radiation. I really hope that we're not going to have to make decisions, worse than that. But if it happens, I certainly would go ahead with radiation. I don't think you'll find a radiation oncologist who wouldn't, right? So we have a patient who needs surgery but can't, we're going to do radiation. And it's almost like a palliative treatment in that sense. Obviously, we're going to hope for a cure, but in terms of the way that we approach the question is, we're going to do our best, right? So if a patient can't get one treatment, then we'll give them the other treatment. And again, I certainly hope that we don't get to that point where patients can't get the treatment they need. And I think that it's a very scary situation. And we know patients with heart attacks are not going to the emergency room. A friend of mine was crying on the floor for hours with kidney stones, afraid to go to the emergency room. I mean, this is happening. All of a sudden, nothing else matters aside from coronavirus. And as a physician and an oncologist, that scares me. So I think we need to start opening hospitals up for other things, and specifically lung cancer.
Amy, can I ask you how you would manage in your practice someone who became positive? So you have someone in the middle of a 6-week course. Let's say they have mild symptoms, but a family member was positive. They get tested and they are now positive, still feel pretty well. And let's say they're right in the middle of their 6-week definitive curative course. How do you How do you approach that?
Yeah, so I think it depends how symptomatic they are. So let's start with the worst case. If patient is coughing, needs to be on oxygen, has having difficulty breathing, if it's a patient that's always on oxygen, that's fine. But if the patient is specifically dyspneic from COVID, they need to stay home. They need to be on a break. I mean, we know that patients can crash at any time. They, sometimes even come off their oxygen and then get really, really worse and code. So it's a very scary disease. I think if someone is really sick, we should stop radiation. The patient is not symptomatic. I would and is towards the end of their treatment, so we really want to just finish up. We don't want to skip treatments, right? So I would say that's a patient that could be treated at the end of the day. We want to make sure that everything is already cleaned in between patients, not in a very serious way on a regular day, but certainly now with coronavirus, the tables have to be cleaned, and but if a patient has coronavirus, the therapists are going to wear full head to toe PPE when they treat that patient, and then also scrub everything down. So that's a patient that should be treated at the end of the day. And that's something that we already do with patients who are on contact precautions for, all kinds of other things. If a patient is at the beginning of their treatment, I would strongly consider putting them on break until they get better. I think it's just something that we really don't know when they'll get sick, if they'll get sicker. We know radiation can definitely, cause, changes in the immune system in terms of, either upregulating the immune system or downregulating it. And it's just something that we really don't know. And I think that we should strongly consider not treating that patient. I mean, the Estro guidelines, also strongly recommended not treating patients and potentially even putting patients on break that test positive. I think another option is, and this is what they did in Italy, is having centers that are for COVID patients and the other cancer centers for COVID negative patients. Obviously, they hope the COVID negative patients stay that way.
So one of the things that also is of relevance here is the treatment of patients with small cell lung cancer. So, even in the pandemic, patients with limited stage small cell lung cancer, we are, prioritizing concurrent chemoradiation therapy as we would. But some of the things we are changing, for example, extensive stage small cell, we are less likely to offer PCI, especially during the pandemic. How are you handling PCI for limited stage disease? Do you feel comfortable still going ahead with it, or, are you choosing to use the surveillance MRI strategy now more so than earlier?
Yeah, so, we always do an MRI, obviously, before starting treatment, just to confirm that it is prophylactic and not palliative whole brain radiation. I think that definitely PCI is something that should be delayed during the pandemic, at least for a month. Let's see how it goes, right? So, and definitely we should be doing surveillance MRIs in lieu of that. I think that's one of those situations that we have the time, it's not a rush, and we have a good alternative. So let's take that.
Can I ask, I'm really interested in just how are you and your colleagues doing psychologically in all of this? There's been a lot of attention appropriately on the people in the ERs and manning the ICUs, and it sounds extremely trying, if not horrific. But hopefully, the people manning the outpatient cancer clinics aren't facing that so much. We have different challenges. You have different challenges. I'm in a place where we have not, at least yet, and I hope never, had the scale and intensity that you are. But are you, your colleagues in radiation, your other cancer colleagues, doing okay with all of this, or are people really concerned about their institution, the viability, the stability of their institution and their jobs? And you hear about institutions cutting back on hours for people and So I'm just interested in an idea of taking the metaphoric temperature of how people are coping with all of this. Of course, patients too, but maybe just for the moment, if you could talk about how you and your colleagues who are taking care of these folks are managing and in your personal lives and professional life.
Yeah, well, thanks for the question. I think it's definitely a time that people are worried, and you can feel it. You can feel the anxiety. It's a different environment. It's a more sterile, more to the point. Let's get this done and let's get this out of here. And it's a very high level of anxiety and concern all around. So you walk into the cancer center, or you walk into radiation, all the doors are open, right? So nobody, you don't want anyone to touch a door handle that someone else just touched. So all the doors are kept open. The coffee machine is closed, right? The water machine is closed. Don't touch anything, don't sit. You don't have people sitting and talking. There is usually a very strong sense of camaraderie and a very strong sense of, we are here to help people. We are here to cure cancer. It's a rallying cry. And now it's more of, oh my goodness, let's do this and get out of here, for everyone's sake. So even just not having patients sit together in the waiting room, because no, don't come in until you're ready, and cover your face, right? So even when I'm doing in-person consultation, that patient wouldn't recognize me on the street, and I wouldn't recognize them because I've never seen their face, right? So it was just it's interesting because yesterday I was doing a telehealth consult, and I was like, oh, I can see your face, like that was like nice, and I was like, even though we're not in person, maybe it's better I can see your face. So we're definitely all in this together, but it's difficult. Everyone's just very, very worried, and everyone knows someone that has gotten really sick or died. I mean, I know multiple people, and then I think the other issues that I've been thinking a lot about are about trainees. In my field of radiation, certain departments have quote unquote deployed their residents to work on the front lines. I'm personally very against that. So I worry about them, so I, have some friends that are in training, and I'll text them like, do you have PPE? Like, let me, my friend's raising money and sending it out. Let me send it to you, because we have to worry about each other. And then the other thing is schools being closed is just really difficult. Like I have so many friends that they and their spouses have lost jobs, so they have zero income. That's really hard. I definitely feel lucky that I still have a job, but it's also hard, to leave kids at home, with no school, remote school, homeschool, whatever you want to call it. So it's not easy.
Thank you so much. I want to make sure we have a time to get to our other topics. So let's take this in the direction of wellness and stress. So how are you all handling really the moral distress of working on the front lines, and obviously with the PPE concerns, and is there any advice that you can provide?
I think that we're not used to this, right? And in terms of stress, there are a lot of questionnaires going out there now, and everyone in the field, their scores are off the charts. And I think that we push forward with a lot of different things, but one of the big sources of stress, I think, in our field is we're talking about delays, we're talking about skipping treatment, modifying treatments to minimize risk. And every decision that we make, I think, weighs very heavily. The stakes are very high. And if we have a bad cancer outcome because we delayed treatment, that's something that's going to stay with us. At the same time, if we move forward with treatment, move forward with the trial, and that patient were to contract COVID, we don't know if it's because of that, but certainly we're going to take that to heart. And we have the well-being of our patients and their families as our priority, but we also have a responsibility to our care teams, our research nurses, our staff, our own families. And I think there's just a lot of uncertainty. And I think it's called to light the importance of having mental health resources, having sort of resources to help people cope through these periods of intense stress. And I think that's available at most institutions now.
But something that Mimi also mentioned, that we are now dealing with these challenges of having issues where there's no good data and we're left with our best judgment about whether we do something that might be more risky from the perspective of the cancer versus more risk borne by the infectious exposures. All of these things where there's no best right answer, and it's just a question of, how do you want to be most vulnerable? And this is coincident with a time when it's not as easy to be collegial with each other. We don't see each other at meetings anymore, except this is, this is what we get. Thank goodness for that. But we are not sitting and chatting with colleagues the way you would have 50 informal bonding moments with your colleagues throughout the day in a collegial enterprise. And we still feel that, but we are bearing a lot of this alone. And I think that's a real challenge. Yeah, we try to do that and avail ourselves of institutional resources, but I think some people will do it that way, and some people just want to connect with colleagues socially in a way that is not available anymore right now.
And well, it's true that you can't connect with people in person as much, but I do think that more than any other time, reaching out and making sure you're connecting somehow with your team, with your colleagues, with your friends is critical right now. So, I mean, I can feel it when I talk to my nurses, I talk to my colleagues, I talk to the research personnel. Everyone is just freaked out. And not only are they freaked out, they are done with this. I mean, we have gotten to the point where everyone is just sick to death of this situation and wants it to be done. And if you're just stuck by yourself in your cube and never seeing or talking to anyone, it can just be maddening. And so I've certainly made it a point to check in with everyone multiple times a day on my team, talking to colleagues, making sure they're doing okay. From just even with friends, I've actually in many ways connected with friends that I haven't seen in a long time on a regular basis. We've got these Zoom calls and cocktail hours and things. I think that's something everyone can do to check in and try to connect as best they can. And then just from a leadership perspective, we're talking a little bit about institutions and fear of people being laid off, and are there financially going to be everybody going to be okay, and everybody going to still have their jobs when this is over? And what our leadership certainly has been doing is every day we're getting emails from our chairman, from our CEO, telling us what our numbers are, what our budget is, and being very, very transparent and very open that everything kind of sucks and it's really tough, but that we're really happy to work with one another and to support one another, and we're going to get through all of this. So I think there are things we can do even in this kind of scary situation.
I think one of the hardest parts about this, in addition to everything that's been said, is how real this is and how close it is to all of us, right? It's not just cases in New York or New Jersey or Italy or China. This is, every one of us knows people, colleagues, patients, families that have been affected by this, and it just hits so close to home that it serves as a reminder every day of how inconsequential sometimes things are that we do on a daily basis. So I think in one sense, it actually levels your playing field a little bit and clears the priorities, but it's definitely challenging to keep your morale up, and like Nate mentioned, to keep your staff's morale up and keep going and keep showing up. It takes a lot. So I would echo what everyone said.
And when I think telemedicine has been great, and there's so many advantages to telemedicine. I agree that there are definitely cases where that is going to stay, but I miss being with a patient in a room. I mean, we didn't get into this, for interactions on the computer. I think our training was the personal interaction. And when we have a very tough day from a research standpoint, from an admin standpoint, we know that we could be in the room with the patient where we connect with that patient, where we have that rapport, we're talking about things, really making that connection, and it gives us this vitality. And I don't have that anymore. I appreciate that telemedicine has many advantages, but there's something to be said about just being in a room with a patient and their family and walking them through this. And I miss that part of the job a lot.
Yeah. I think also I try to remind myself that, this is crisis mode. I always tell people, like, don't do more than two big things at once. Like if you're moving and having a baby, like that's it. Like don't take your boards, or, if you're starting a new job, don't, also, change, your home or get married or, don't do like too many big things at once because, it's stressful. And this is just like literally everything all at once. Like our jobs have changed for many people, their finances have changed, whether themselves or their spouse, the kids are home, it's just like, and then a lot of people have no people or their own family are dealing with illness. So there's just so much going on all at the same time. And I really feel that, it's important to not make any decisions and not take any thoughts too seriously about, oh my goodness, I can't do this, or this is going to last forever, or what's going to happen, or why is everything changing? This is a real crisis and it definitely will end. And until then, our job is to put one foot in front of the other. And I want to also echo what Nate said, there are so many different ways of connecting, using tools. One of the best things that I've been using is WhatsApp groups with different physician groups. I have one, with different physicians from all different specialties, and we check on each other like, hey, one of my friends is, an infertility doctor, and, they had to lay off all their staff, like all of them. Like, it's just awful. And I'm so grateful. Like, okay, at least not all my coworkers have been laid off, and then I have another friend on the same chat who's, a cardiology fellow who's now working as an attending, so it really helps to get perspective and also get reassurance that people are able to adapt and continue taking care of patients. And again, thank God that the surge is ending and going down. So WhatsApp, I find, is an amazing way to, continue to connect with people.
Thank you so much. I want to make sure we have obviously just a few minutes to address some of the questions, but I do want to thank the faculty so much for participating tonight and sharing this insight with one another and with our listeners. And thank you so much, Dr. Knoll, for being available to discuss all of this with us. So I'm now going to open up the question and answer portion of the webinar. So if you go to the question and answer box, it's on the right corner of your screen, you can type your question directly in the space that's in the box and then hit submit. So I'm just going to pull up a couple of the ones that we have here. So one of the questions we have is, if patients get COVID-19 during their chemo radiation, would you hold TX, I guess it's Taxotere, or
treatment.
Thank you, until they are better?
So if a patient is symptomatic, I definitely would hold treatment until they're better. If they are not symptomatic, I would consider treating them at the end of the day. So basically after everyone else has been done with their treatment. And there are other situations, like if the patient had one treatment, maybe we would, wait, and that's almost like not even a break. So it really depends also, how symptomatic they are and how far along they are into their treatment.
From a chemotherapy standpoint, if we're talking about palliative systemic treatment, if we had a positive patient, I think we all agree that we would hold treatment. There are so many unknowns, so many variables, and there are very few instances where we can't delay treatment for a little while.
Yeah. Do you find that that's hard to convince patients of? I sometimes, it's like I had like a friend of a friend of a friend, want to know, should I get a second opinion? I was like, by the time you get a second opinion, you'll have already gotten your treatment delay, your treatment, which was only delayed for 3 weeks. So we'll be fine,
I think that during the pandemic, folks are scared enough and they're freaked out. I think they would be okay. I haven't had a situation where I've had to talk to a patient about delaying their treatment, but I would assume that if they test positive, they would be totally fine with holding off on treatment.
Yeah,
I think part of it's actually more of a problem trying to convince people who need to come in to get their treatment because they're sick,
Right.
to do it rather than staying home. I have people that on at least a couple occasions in the last week, should have been calling 911 or coming in, urgently to be seen for very concerning symptoms, and they're
Yeah.
just staying at home because they're terrified.
Yeah.
We have to really convince them to get that treatment. So if anything, it's the other way around.
Great. So if a patient has recovered from COVID-19, are you comfortable with starting thoracic radiation therapy, like for stage 3 disease, considering damages done by infection to the lungs?
Yeah, so, I would consider getting a CAT scan, to confirm that they're, better, but it's really a clinical diagnosis in either case. So yes, I would feel comfortable starting radiation if they've fully recovered.
I think we need to acknowledge we're talking about a curable cancer setting with high risk. I mean, we don't want to minimize the risk of COVID-19, but at the same time, we have to acknowledge that stage 3 lung cancer is a very important issue to address, and we can't defer on treating that for months at a time without it incurring major issues. So I think you have to acknowledge with an informed patient that there are unknowns, but you do the best you can under the circumstances. And I think that you really need to prioritize giving the clearly established standards of care that increase, that are associated with curing patients with a life-threatening disease.
Yeah, we're mitigating risk, but we can't compromise the cancer outcomes, and we have to move forward. At the same time, we acknowledge that we are watching closely, and there are a lot of unknowns. And I've had a patient now was positive. It's been several weeks. She's recovered, but her breathing isn't quite the same. And the long-term effects of these infections, we're going to have to wait and see.
Yeah. I mean, I'm worried overall about cancer care in the United States. Are we going to be seeing a lot more stage 4 patients from all diseases because people just stayed home and didn't go for their, that course of antibiotics that didn't work, that led to the x-ray, then the CAT scan, and then the diagnosis of lung cancer? If every one of those steps takes a month instead of a week, patients are going to get diagnosed much, much later. So I agree. If we have patients with confirmed stage 3 disease, we got to get them on treatment, because the risk of dying from COVID is still very low compared to the risk of dying from their known lung cancer.
And Dr. Knoll, you actually referenced the guidelines a little bit earlier, but with the ASCO and Astro recently updated guidelines, can you maybe expand a little bit on how these guidelines might be impacted during COVID-19?
Yeah, so ASCO and Astro have their own, facts, like frequently asked questions, which give, very general information about, staff and cleaning protocols and masks and that kind of stuff. But what I found very informative specifically for lung cancer is the Astro guidelines. So it's European and American guidelines together that was published in Radiotherapy Oncology, so the Green Journal. And I don't know if there's a way we can post it, but I can send you the link. And that goes through, a lot of the cases that we discuss, which is, for stage 1 versus stage 3 versus small cell. When is it reasonable? And obviously with the caveat that, this is new, and this is something that hopefully we won't have to deal with much longer. But to echo what everyone else said, we don't want to and shouldn't compromise cure when we have the chance.
Great. Thank you so much, everyone. That is all the time that we have for questions tonight. So again, a huge thank you to the faculty, Drs. West, Dr. Pennell, Dr. Liu, Dr. Aggarwal, and Dr. Knoll for taking the time out of your extremely busy schedules. I know you all have to virtually sit down with Enclave and discuss these very, very important subject matters with our audience this evening. And thank you to our listeners. I really hope you were able to gain some valuable insight into the clinical practice and how much it's changing in oncology during this pandemic. So just a reminder, you will be able to listen back and watch this again shortly following this webinar. And our next one is scheduled for next Wednesday, April 29th at 8 p.m. And for next week's program, we'll have another very special edition. We'll be welcoming Dr. Brendan Stiles, who's a thoracic surgeon at New York Presbyterian Hospital, and also an associate professor of cardiothoracic surgery at Weill Cornell Medicine. So we're very much looking forward to having him. And in closing, you can continue to visit enclave.com, sign up for our e-newsletters, or follow us on social media on Twitter, LinkedIn, and Facebook to get updates on when we will be broadcasting more of these webinars. For all of your oncology news, you can visit enclave.com, where you can also find our COVID-19 Resource Center. So that is the conclusion of this evening's webcast. Thank you so much, everyone, and I hope you have a wonderful night.
Night.
Thanks so much for having me. Have a great night, everyone.
Good night.